simplex.
Not necessary. So another giveaway for herpes simplex is that it affects the temporal lobes. All right. Another giveaway for that. Over here, we don't see temporal lobes. Okay, we see frontal lobes. That is the reason it is not herpes simplex infection. We talked about that neck stiffness. It's usually related to meningitis. We know that herpes simplex can cause, encephalitis. We know that tuberculosis can cause meningitis. That's known as TB meningitis. All right. So that is how we can exclude the rest. But they are the neurocystic necrosis, primary CNS lymphoma, tox. All of them are found in immunocompromised patients as well. So okay. But the distractor over here was that, if it's meningitis, then it may be herpes simplex or TB. The reason it's not herpes simplex because there are no temporal lobes that are getting affected over here. So we can exclude that out. In tuberculosis, let's see that if it's right or not. Yes, it was tuberculosis infection. Another thing, what is the lab picture in tuberculosis infection? Will the neutrophils increase or will the lymphocytes increase?
Lymphocytes will increase.
Lymphocytes.
Exactly. It is the only infection which is bacterial in nature, but over here you will see lymphocyte increase. Okay. You won't see neutrophil increase in the classic picture of meningitis. So if it's a bacterial meningitis picture, usually you see neutrophil counts that are increased, but in tuberculosis, it is the only bacteria where you will see lymphocytes that will be increased. All right. In herpes simplex, what will you see? Okay, what will happen to the glucose concentration in tuberculosis? Will it be low or will it be high?
It will be low.
Below.
Low? Okay, very good. Again, bacteria feeds on glucose. That is why it's low. So if you see glucose low, then that means you're talking about bacteria or what else?
Fungal.
Fungal. Very good.
Fungal.
Bacteria and fungal. Virus does not feed on glucose. If you see low glucose, that means you're talking about either bacterial or fungal. Then you need to see the neutrophils, lymphocytes. If it's neutrophils counts that are increased, then that means you're talking about a bacteria. If it's the lymphocyte count that's increased, that means you're talking about either a viral pathology or it's tuberculosis. All right, you have to figure that out. Other thing about herpes simplex, I mentioned that it causes temporal lobe infarcts. You can see this over here. It's written over here, right? I mentioned that early that herpes simplex affects temporal lobes, and that is why you could kind of exclude it out from the WIGNet. Okay, so if we kind of go through that, we know how tuberculosis meningitis occurs. Another giveaway is the thick gelatinous exudate that's present over here. Again, what hydrocephalus? What do you mean by hydrocephalus?
It's obstruction of the outflow of the seeds.
All right. What does it cause?
It will cause ventriculomegaly.
Exactly. It will cause ventriculomegaly. It will cause increased intracranial pressure, like I talked about, headache, nausea, vomiting. They all increase intracranial pressure symptoms. That means two things. Either hydrocephalus is occurring because of any obstruction, or hydrocephalus is occurring due to any sort of mass that's kind of impinging on the ventricles, and that is why they're unable to drain. All right. Okay.
In addition, in herpes simplex, there will be hemorrhagic infarcts. So we will found red blood cells in CSF.
Okay. So we talked about neurocystic necrosis. Neurocystic necrosis is usually a cyst in the brain. It's caused by taenius solium. And what is the treatment for neurocystic necrosis? What do you give? Somebody's mic is on. Please mute yourself, whoever's mic is on. All right. Yeah. So neurocystic necrosis, what is the treatment for neurocystic necrosis? What do you give?
Praziquantel. Antiparasitic.
All right. What else? Anybody else? So you give albendazole for neurocystic necrosis. All right. Again, primary CNS lymphoma, very high yield for you to remember that it's linked with HIV. Toxoplasmosis, again, you will see like ring type lesions multiple interparenchymal lesions in the brain. All right. So again, we talked about that. I think this is it's easy of a question. All right. Next question, guys. So physical examination, alert, oriented, muscle strength is normal. MR shows diffuse cerebral atrophy with no focal mass lesions or area of demyelination. All right, cerebral atrophy, and I think the patient has HIV. Yeah. So what do you think happened? Which of the following is involved in the patient's disease processes? What do you think is happening? So the patient has HIV and the patient has diffuse cerebral atrophy. What do you mean by that? What's
Diffuse
happening?
cerebral atrophy, that means that he is having maybe a chronic, yeah, it's Alzheimer disease. That's
Mm-hmm.
we have atrophy, and
Exactly.
uh, with the HIV/AIDS, we should think about HIV dementia, and the most predominant cells in that it will be the macrophages because yeah, it will.
All right. Do we all agree with macrophages?
Yeah.
All right. Okay, let's go and see. Yeah. So it's HIV associated dementia. We know that HIV causes a lot of other opportunistic infections. What is the meningitis in HIV patients called? Most of the
Will be
time,
called as it will be as it will be aseptic meningitis or something called.
yeah.
Yeah.
Another type of meningitis that HIV patients are kind of like kind of immunocompromised to is cryptococcal meningitis. Um,
Cryptococcus, yeah. Mhm.
Cryptococcal meningitis, if they have a CD4 count lesser than 50 or lesser than 100, they get like kind of so do that. So again, there are a lot of opportunistic infections that you need to remember for step one. We will discuss them in the immunology module. All right. So HIV patients, the HIV patient had mild dementia that's known as HIV associated dementia, and we know that HIV kind of affects the CD4 T helper cells. All right. The CNS infection is associated with the change in viral tropism to microglia and macrophages. All right, we know that. So again, it was something that it kind of made sense that it's macrophages. It cannot be oligodendrocytes. Why cannot be oligodendrocytes? Why not that?
Oligodendrocyte is responsible for myelination, and here what we see is like a cerebral atrophy with no focal mass or areas of demyelination.
Exactly. So again, cytomegalovirus is very like endothelial cells oriented. So you need to remember that endothelial cells, cytomegalovirus kind of like affects those cells. Again, macrophages is for HIV, and you do CD4. You see CD4 helper T cells if you want to see how deep the infection is or how immunocompromised the patient is. It's usually a marker that assesses how immunocompromised the patient is. All right, again, so we have a 23-year-old man, seizures, okay, fever, headache, past 2 days, and he was talking nonsensically, okay. What sort of aphasia is this? If, for example, if you're able to understand and you cannot talk, what sort of aphasia is that?
Receptive aphasia.
All right, what's it called?
Broca's aphasia.
Wernicke's. Wernicke's.
Fluent
Wernicke.
Broca.
aphasia.
So you can understand.
It's
So
Broca. Broca.
But
Wernicke is intact.
Can't speak.
Wernicke is intact.
Yeah,
exactly.
infection.
Very good. All right. Okay. So the patient works at a fast food chain. It does not take drugs. Okay. Temporal lobes. I mentioned it to you earlier. What do you think this is?
Herpes.
SV1.
SVV. SVV1.
Exactly. We talked about how temporal lobes get affected in herpes simplex virus. So we know that they're talking about something viral pathology that's going on. So Proteins, okay, in glucose, the glucose will not be low. We know that, right? Because in bacterial and fungal that happens, it's going to be normal. So, okay, then we talk about the cells. I think we have the answer already. What do you think the answer is?
It's C.
C.
It will be C.
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 C
C.
or A?
It will be C because in HSC-SV there will be hemorrhagic, hemorrhagic, so there will be erythrocytes.
All right. Yeah. So we know that lymphocytes are found in any viral pathology. Along with that, you will also see erythrocytes in herpes simplex. So this is a picture over here. This picture is very important for you to memorize. In bacterial meningitis, you see that the cell count is really high. Neutrophils, glucose is less, protein is greater. In viral meningitis, you see that there's the lymphocytes predominant, fungal or tuberculosis, again, lymphocytes, and herpes encephalitis, lymphocytes and erythrocytes. Okay, how do you differentiate encephalitis with meningitis?
Meningitis, there will be no cerebral signs, but in mostly in meningitis, there will be meningeal signs like meningeal irritation, there will be neck stiffness, these things. But if they involve the encephalitis, can involve the brainstem, can involve the medulla, can involve also the basal ganglia.
Seizures.
Neck rigidity.
Seizures.
What else? What else? So we know that meningitis, it is the inflammation of the meninges, whereas in encephalitis, it is the inflammation of the brain tissue itself. All right. If we talk about the differences, they both can cause fever and headache, but encephalitis, it can also cause confusion, seizures, or sometimes it can cause personality changes. All right. So if you're talking about a more prolonged, a more chronic state where you have personality changes, then that's more likely encephalitis. If you have more of an acute presentation along with high grade fever, then that's most probably meningitis. All right. Okay. Then we have the next question. Leukocyte count is 19,000 with 20% band neutrophils, blood culture and obtain lumbar punctures performed. Gram negative cocci. What's happening? What do you mean by gram negative cocci?
Neisseria.
Neisseria meningitis.
Meningitis.
Exactly.
Yes,
Again, they gave us a classic picture. Neisseria meningitis is very common in, like people who live together. Neisseria meningitis and Mycobacterium tuberculosis. Again, two of the infections that in which you advise contact precautions for the family and the patient. All right. Then we have, okay, so how do you think it goes through? How does a gram negative cocci kind of transport to the meninges? How?
running through the pharynx could be.
Yes, through the pharynx it goes to the brain.
All
B.
right. So is it B or C? B?
B.
Choroid plexus.
Is through the choroid plexus.
Exactly. So we know that acute bacterial meningitis, it is life threatening. All right, and meningitis, it's kind of colonizes the nasopharynx, and then from the nasopharynx it goes to the bloodstream, and then it gets into the choroid plexus and the meninges. That's how it kind of penetrates into the brain. All right. So again, aerosolized droplets. Okay, what is the prophylaxis for Neisseria meningitis? For example, if your roommate has Neisseria meningitis and you take him or her to the hospital, what prophylaxis would the doctors give to you?
Rifampin. Rifampin.
Very good. So rifampin, ceftriaxone, you can give whatever, but it's mostly rifampin on USMLE step 2 or step 1. All right. So we have a 38-year-old man brought to the emergency department after a generalized tonic-clonic seizure. Okay, so fever, bilateral papilledema, and neck rigidity, condition versus patient dies, autopsies performed, the brain histopathology is shown below. What is this?
Soap bubble appearance. So
Yeah, it's Cryptococcus.
Take
focus neophorus.
tool of
It's
Cryptococcus.
Cryptococcus neoforms.
All right. So what do you think the answer is?
E.
It's a fungi.
Yeast with polysaccharide cap.
Exactly. So this is how cryptococcal encephalitis looks like. Cryptococcal both causes meningitis and encephalitis. Again, I said that meningitis kind of progresses to encephalitis. Another giveaway for cryptococcal meningitis is that the patient is, usually patients who are having advanced conditions, like I said, particularly AIDS, they get cryptococcal meningitis. Um, and what else? Oh, yeah, what is the treatment for cryptococcal meningitis? What do you give? Come on. What is the treatment for cryptococcal meningitis?
Amphotericin B for this
Amphotericin or fluconazole.
Very good. Somebody else? So cryptococcal meningitis, you have to give IV amphotericin B along with fluclocysteine, and then you taper it off with fluconazole. All right. So amphotericin B and fluclocysteine, you give it for 2 weeks, and then you tape off the medication by fluconazole. So fluconazole you give for 2 months, and that you're going to give for 2 weeks. After that, you have to stop that and taper it off with fluconazole. All right. There is this thing called India ink or silver stain. It's absolutely redundant on the USMLEs. I think this is also replaced by another sort of stain that they ask you. I have forgotten what it's called, but they
Musicarbide.
would,
Yeah,
what's that?
musicarmine.
And
Yeah, exactly that one. I have forgotten that. India Ink, they won't ask you. It's replaced. All right. We come to the next question. There is hepatosplenomegaly. All right, 2-month-old boy. Poor feeding, frequent vomiting, 15 percentile, and the head circumference is 96 percentile, which means he's having hydrocephalus. All right, hepatosplenomegaly. Okay, it's very easy. What do you think this is? What sort of torch infection is that? Where you see hydrocephalus, urochorioretinal regions, enlarged ventricles,
Toxo.
tox.
toxo.
Very good. All right. So is it an intrapartum infection or an in utero infection?
In utero. In utero. C.
It's B or C?
C. In
C.
I think C.
Yes. So this is torches infection that I was saying. It comprises of toxo, syphilis, rubella, CMV, herpes simplex. Very high yield. These are very high yield for you to remember. Okay, they're going to give you a lot of intracranial calcification. So you will get confused a lot between tox and cytomegalo. All right, because as you can see that they both have calcifications, but you need to see that what type of calcifications are occurring. Are they diffuse or are they solidly located in the ventricles? All right, so when you see that there are ventricles and if those are not calcified, then that means you're talking about tox and it's not CMV, because they kind of confuse you in that. All right, again, rubella, it's very easy that it has cataracts, heart defects, PDA, sensory neural hearing loss. Syphilis, we know that it's rhinorrhea, squamating rash. They have skeletal anomalies as well. Herpes simplex, they don't ask you, but these four are very high yield for you to remember. All right. Okay, I think I talked about that. Yeah. Okay. Next question. Okay. So what are they saying? We have a 24-year-old man, ED due to seizures, 2 days of worsening fever, headache, and vomiting. Physical examination shows signs of meningeal irritation. All right, there's signs of meningeal irritation. Autopsy examination shows congested leptomeninges, fibrinopleural exudate not shown. Microscopy reveals numerous amoeba in the exudated brain tissue. Okay, which of the following is most likely entry of the amoeba? All right, what do you think? We know that amoeba travels through nose.
Cubiform plate.
From where?
Cubiform plate.
Very good. Where do you think this is? I'm gonna zoom in.
E. The olfactory bulb.
Yeah. So we know that, a lot of patients, I don't know if you guys followed the news, even in, those of you who are from Pakistan, there was an epidemic outbreak where patients were dying with amoebiasis. And there was this pathogen that was called Naegleria fluorescein. I hope you remember that. And a lot of people died because it caused, when Muslims did wudu, so they have to put water into their noses as well. And when they did that, the amoeba traveled through the nose to their brain, and it caused, inflammation, and people died. So, okay, we know how it gets traveled, and we're going to talk about that. All right. See, oh, it was the same. Okay, yeah. So it was Naegleria fluorescein, like I said, and again, it travels through the nasal mucosa. Again, like I said, swimming, diving, water skiing, or even Muslims when they do wuzu, it travels through the nose to the brain, and then causes meningitis, widespread leptomeningeal inflammation, and the patient dies. It's a very, very rapidly aggressive disease. The patient dies within 2 to 3 days. So that's how fast it is. All right. Next question. Okay, what is this?
Is it as well?
Streptococcus neoformis.
It is Cryptococcus.
Streptococcus metformin. Thick
Exactly.
polysaccharide capsule.
Exactly. So that is why I said that the pictures are very high yield. Whatever pictures are coming in your UWORLD, very high yield. Get through the first aid, get through the pathoma, memorize each and every picture. I know it's really hard, but it saves a lot of time. I mean, you don't have to read the entire question. You know what the picture is, and then you just go and see what the question is. Oh yeah, I gave away this answer.
Mm-hmm.
Yeah,
Info B.
Amphotericin
amphotericin B.
Amphotericin B. And
Yes.
So
clear halo of the mucocarbon stain.
exactly. We know they're talking about cryptococcal meningitis. So I told you that you give amphotericin B along with flucocysteine, and you taper it off with fluconazole. So yeah, it's written over here. Yeah. Initial treatment amphotericin B with flucocysteine, and then you taper it off with fluconazole. So for 2 weeks, you give amphotericin B plus flucocysteine, and then after that, you give 2 months fluconazole. All right. India Inc. Again, it's obliterated from USMLE. You don't have to remember that. Lumbar puncture, decreased glucose and increased protein. Again, cryptococcal occurs in those patients who are immunocompromised, AIDS patients. And yeah, this is a picture. It's of thick polysaccharide capsule, which are clearly linked to Cryptococcus neoformans. You have to kind of go through the picture if you want to memorize it. And yeah, I think we talked about that. Okay, where do you give voriconazole? In what patients do you give voriconazole?
Aspergillus.
Yeah, very good. You give voriconazole and aspergillus. Where do you give Jancy clover?
This is in cytomegalovirus retinitis.
Exactly. So you give CMV patients Jancy clover. What if you are resistant to Jancy clover? Then what? What do you give?
Foscarnet, I think.
Sacnet. Yeah. Where do you give ceftriaxone?
Reason for pneumococcus, many diseases. I think.
Exactly. So we know ceftriaxone is a third generation cephalosporin. You give ceftriaxone in a lot of diseases such as advanced UTIs, advanced meningitis patients. So usually the go-to antibiotic for every doctor is ceftriaxone or it's ampicillin. That's the go-to antibiotic for every doctor. So that's there. Where do you give primethamine? There's primethamine. Where do you give primethamine?
Malaria.
Very good. Somebody else?
Malaria and toxo.
Exactly. For toxo as well. All right. Next question. CD4 count is very low, which means you're talking about, okay, HIV is very high. CD shows a hypodensity of the left frontal lobe, ring enhancement. Okay. Two similar lesions are present in the basal ganglia. So what's basically happened is that they have ring enhanced lesions, CD4, immunocompromised, which means they're either talking about two things, either tox or neurocystic necrosis. What do you think the answer is? How is tox different from neurocystic necrosis? I told you guys that.
Come again. What's the question?
The question is, how is toxoplasmosis different from neurocystic necrosis?
In the toxoplasmosis, the CD4 count should be less than 100. So here, if the CD count is the less than 100, it is more in the favor of toxo.
Okay. Why not neurocystic necrosis?
Because of calcifications in the ventricular area.
Okay. And how do you see, how does tox get transmitted?
Contaminated particles, it spreads through contaminated particles.
I think
in the skin, the foot.
Neurocystic causes, it will be near the ventricles, isn't it? And then in toxoplasmosis, it will be scattered more.
Facility.
All
Actually,
right.
the patient works is the in the SLAM is the patient works in the food processing facility and has not traveled recently. So it can be neurocystic cirrhosis because of ingestion of contaminated food particles because of the nature of work of the patient.
I told you.
One
guys
is animal physics and the other one is human physics.
All right. So how do you, what's the answer?
Ganji.
Yeah.
So what do you think?
C. C is in cat.
C. Gestional.
Yeah. So we know that we're talking about toxoplasmosis over here. It wasn't neurocystic necrosis. I told you guys that in toxoplasmosis, you will see a lot of ring enhancing brain lesions, and it's usually in patients who have a CD4 count lesser than 100. You see that the CD4 count was lesser than 100. It suggested toxoplasmosis. Tox infections usually come with exposure to cat feces. Again, very important high yield for you to remember. Again, TMP SMX is the prophylaxis. You give dalazine, primethamine, leucovorin. It is the therapeutic treatment for toxoplasmosis. Toxoplasmosis causes encephalitis as well. So we kind of knew that as well. And yeah, so mosquito bites, we don't know. It's not mosquito bites because West Nile, Zika, sometimes cerebral malaria, by the malaria as well. And then we have herpes virus. We know how it's transmitted by close contact. Cryptococcus neoformans is we know it's through bird droppings. All right. There's also this fungal infection that gets transmitted through bat droppings. What's that? Bat droppings in a cave?
Histoplasma. Histoplasma.
Very good. So rodents, most of the times they won't say that a patient is going to a cave and that is why he got histoplasmosis. Sometimes they're going to say that, if there are bats or, any sort of other rodent and they inhale the spores through the that. So that can also be histoplasmosis. All right. Okay, Bartonella, we know it's cat scratch disease. Again, very important. It's the bacillary angiomatosis. It causes bacillary angiomatosis in advanced AIDS patients. Very high yield for you to remember. Another thing that it affects the endothelial cells. I don't know if it's mentioned over here, but yeah. Bacillary angiomatosis, it affects the endothelial cells as well. So kind of memorize that. They're going to ask you. This is very high yield. And syphilis, it's already very high yield. I don't need to explain. All right. Okay, so then we have the next question. All right, again, whenever you see a question like that, go and see the laboratory findings. All right, glucose is very low. What do you think this is? Glucose is low. What can it be?
It's either bacterial,
Bacterial or
fungal.
Bacteria or
Exactly. So we know it can be either bacterial or it can be fungal. Then we see that there's some erythrocytes, and then we see that the neutrophils are very high. So that means
bacterial.
Bacterial.
bacterial. Very good. Okay. So what do you think the answer is? So there is this patient, Massachusetts. All right, 44-year-old, headache, confusion, type 2 diabetes, pupillary reflexes, phonoscopic findings are normal, rigidity. What do you think the answer is?
Right.
So we know that it cannot.
Strep pneumoniae. The lancet shape, gram positive cocci. That is
Lungs were cleared. In the history, the lungs was clear, I think.
but there is meningitis. Meningitis is caused by strep pneumoniae.
Yeah, it can. Yeah, respiratory illness. Okay.
Yes.
All right. Yes. So we know there was strep pneumo meningitis. Again, S pneumo. It also causes meningitis. What is the treatment for this sort of meningitis?
Sick. Triazone
Yeah. In older patients
and
with a
macrol-
in
macrolides,
yeah, like
azithromycin,
yeah. So what if this patient was 60 plus? What else the patient would have been prone to? Listeria monocytogenes. And for Listeria monocytogenes, what else do you give?
ampicillin,
Ampicillin, exactly. So if a patient is 50 plus, 60 plus, you will give ampicillin as along with the treatment with steroids. You also give steroids because there's also some eye problems that are going on over here. So you also give steroids and ceftriaxone and ampicillin if the patient is very old or if the patient is a neonate. All right. So I think we talked about that. Again, bacterial meningitis, CSF glucose. I think this is very clear, nothing to kind of go through. All right. Next question. Okay, she's admitted to ICU. The patient becomes unresponsive the following day and dies overnight. All right. Bilateral hemorrhagic necrosis of the inferior and medial temporal lobes. What do you think this is? 9-year-old girl.
herpes simplex,
Pet cat, disoriented, worsening headache.
Herpes simplex.
See, so this is very easy. So you just bent and just read the last line, and then you said, boom, this is the answer.
Temporal.
All right. Again, you give acyclovir as treatment for that. This is very high yield. The diagnosis is very high yield for you to remember. We know that HSV comes through close contact through by kissing. So if you kiss a child, through saliva, it's getting transmitted. All right. What other condition gets transmitted through saliva? Because what's known as a kissing disease? What's that?
Infectious mononucleus.
Exactly. Epstein-Barr virus. It gets transmitted through saliva as well. All right. Next question. So, okay, what's happening? So we start reading. Okay, pharmaceutical researcher developed novel agent to prevent meningococcal diseases. Pili antigens, Neisseria meningitis are extracted and used to generate antibodies. All right, antibodies are administered in experimental animals with no prior exposure to any meningitis. Those animals, along with control animals that had not received. All right, what's happening? Compared with the control animals, a significantly greater portion of the animals that received remain healthy and other fixes. All right, so what do you think is happening?
Attachment to the nasopharyngeal epithelial cells.
Is it right? We all agree?
Yes.
Yes.
We all agree? Okay. Right. Okay, so we know that at the pili, it gets attached to the nasopharyngeal epithelium. Again, we talked about how a Neisseria meningitis travels. We talked about that earlier. Again, virulence factor is very important. Over here, it's IgA protease, very high yield for you to remember. Okay, what is the treatment for in meningitis? What do you give?
Rifampin, ceftriaxone.
Except Rexon, yeah.
Sorry.
All right. Again, next question, white patches on the oropharyngeal mucosa. What does this mean? What do you mean by oral?
Candida. Oral candida, fungal infection.
Exactly. So, how do you differentiate candidiasis with leukoplakia? They both have white patches on the tongue. How do you differentiate it?
One can be
Can be
scrapped and one
scraped off. Can be.
Can't be scrapped. Hairy leukoplakia can't be scrapped, but the oral candidiasis can be.
Very good. All right. Brain imaging reveals no intracranial masses. India ink staining demonstrates several yeast forms with thick capsule, which is the primary site of the infection. So we know that they're talking about cryptococcal meningitis, right? All right. So what do you think it's getting affected?
The lungs.
Yep. So again, all of them very high yield. Candidiasis, very high yield. We know that candidiasis occurs in immunocompromised patients. You also see sometimes candidiasis in diabetes mellitus patients. Blastococcidio, histo, very high yield for you to remember. They ask you this a lot on USMLE step 1. Cryptococcal, again, very high yield for you to remember. Yes, I think, again, nothing to go through over here. Very easy. All right, next question. What's this? What's happening? What's this?
Ring enhancing lesion.
like lesion.
So
Ring enhancing lesions.
Okay.
multiple.
Plasmosis.
Multiple. On the other side too. Multiple ring enhancing.
All right. So it's toxo.
Toxo.
Plasmosis, yes.
Very good. So you see multiple ring enhancing lesions. Again, toxoplasmosis get transmitted through undercooked meat. What happens in toxoplasmosis? We know that if a pregnant woman eats, undercooked beef, she develops tox, and it's one of the torches infection, and the baby will have defects. All right. Okay. What are the defects of the baby? We talked about that.
Microcephaly and retinitis.
Chorioretinitis and what else?
Reventricular calcification.
Very good. All right. Then we have the last question for today. Glucose is 70. So what do you mean by that? Glucose is not low, glucose is high. Then that means it's not a bacterial or fungal infection. It may be viral in nature. All right. And we saw that the lymphocytes are very high. Again, viral in nature. It's not herpes simplex because there are no red blood cells. All right. Then what do you think this is? 6-year-old boy. Neck stiffness. All right.
Antirovirus can cause meningitis.
Meningitis.
Enterovirus?
Yeah, the
Yeah,
virus.
the most common cause of meningitis in children.
No meningitis. No.
Exactly. So it was enterovirus. Why not? What happens in mumps?
Parotitis, parotid glands enlargement and the infection of the parotid gland.
Exactly. And what else?
Is this cervical lymphadenopathy as well?
Very good. All right. Okay. So we know that usually mumps usually occurs in an unimmunized infant. All right. So we see that the There is nothing of, they say that the vaccinations are up to date. That's also a different differentiation, that it cannot be mumps, because mumps usually occurs in patients who are unvaccinated, and the patient was vaccinated over here. So it cannot be mumps, leaving us with enterovirus. So you, again, if you do not know that enterovirus is the answer, you can eliminate it out the answer, the rest of the answers, and come to a conclusion of what. All right. Again, very high yield. The entire topics that I mentioned until now are very high yield. Okay, let's do two more. I have 5 minutes, so let's do two more. Okay, glucose is normal. Leukocytes are very high. Neutrophils are very high. What do you think is happening? Gram-positive rods. Where do you see gram-positive rods?
Yeah,
Yeah.
gram-positive roads, tumbling motility. This is the keyword.
Listeria.
And the old,
Hysteria.
very
How does it get transmitted?
contaminated.
Contaminated food. Yeah.
Contaminated food.
Yeah, contaminated food. Yeah.
Exactly. So we know that in sort of a listeria occurs in, again, either I said 50 above, like I mentioned 50 above, 60 above. Why did I mention 50 above, 60 above for listeria? Because most of the patients who are 50 above, 60 above, they are immunocompromised. Instead of, for example, diabetes mellitus, they might have hypertension, or they may have, some disease that's going on within them. They're not perfectly healthy most of the times. That is why they get non-immune to listeria as well. And again, the patient underwent kidney transplantation that made him immunocompromised, and gram-positive rods with tumbling motility. You see that with listeria monocytogenes. I talked about how ampicillin is the antibiotic of choice. You also give it as kind of along with ceftriaxone if any patient is coming to you above 50 years old or above 60 years old. All right. Okay. Last question for us today is, okay, again, I hate these types of questions. A study was conducted to determine the utility of adjunctive therapy in bacterial meningitis. Patients with acute bacterial meningitis whose CSF showed gram-positive diplococci, all right, they were divided into two groups. The first control group was given systemic antibiotics only, and the second group was given DEXA, followed by systemic antibiotics. I told you guys that how steroids are really important in meningitis as well, because a lot of times there are ophthalmologic complications in meningitis as well. So kind of to reverse them, we give steroids. So compared to the control group, patients in the experimental group developed fewer neurological sequelae and had a lower risk of death. The experimental patients most likely benefited from the use of the drug due to which of the following? What do you think the answer is?
Decreased inflammatory response. B.
Yes.
Again, very kind of we know that steroids help, with the inflammation, right? So that is why steroids, most of the doctors also give steroids. Oh, nothing is working, give steroids. Why? Because if it's nothing is going to work, at least steroid is going to help you achieve results. So that is it for today. We are done for today. If you have got any other
Dr.
questions.
Maheen, yeah, Dr. Maheen, just one question.
Yeah.
That is regarding the classifications you have mentioned for herpes and also toxo. Could you just tell me about that? Periventricular classification is for toxo.
So it's, who is going to say that where are diffuse intracranial calcifications and where do you see periventricular? So periventricular calcifications you see in CMV. Remember perivent, so V is CMV, right? So CMV, periventricular. So the V in periventricular is CMV, all right? So kind of remember from there, the periventricular calcifications you see in CMV, and in the other, you will see the diffuse intracranial calcifications.
Thank you.
All right. Okay. Anybody else? Good job, guys. How many of you have your step 1 in a month? How many of you saw? All right. I wanted to make an announcement that we have decided to make a separate group for those people who have their step 1 in a month. Or in I think Dia, your mic is on. All right, yeah. So we have decided that we are creating a group for those people who have their step one in a month, all right, and they have 3 to 4 weeks for their big day. So we have decided to make a separate group for those people because, as you can understand, that they must be in their accelerated preparation zone, and that is why we have decided to test them with NBMEs and kind of assess their score. If they're coming on a good score, and we feel that they're ready for the exam, then they will have to go and take the exam. But if we feel that they need extra preparation, then we will, kind of give them extra time and effort to help them improve their study pace. So that is something I wanted to say. Don't worry that we're not including the rest of you, but it's just something that we thought that, in during your last days of final revision, you need some extra guidance and extra motivation. That is why it was we decided to make a separate group for those people. All right, we'll be putting it in the chats as well, on the WhatsApp group as well, that if there are people who are in their last month of their dedicated period of studying, they can join them. So don't worry about that. All right, I think it's Dr. Ahmed's session. Dr. Ahmed, are you here?
Yes, Dr. Maheen, I'm here.
Yeah, so I was just telling them about the WhatsApp group that we thought that we'll make a separate group of students who are going to have their step one in a month.
Yes, so that's quite good. So Dr. Maheen just came up with this idea. I think I have already mentioned this, but yes, those who are just about to give their exam within a month, we are going to make separate group, and for them, we might, their task would be separate from other people. So we'll be working on the task as well. As Dr. Maheen mentioned, you should be on your accelerated phase in such short time span. So that's why we feel a need. And next thing which I want to mention, that our mentors of research are working day and night. They have just prepared the entire schedule, the entire roadmap, how things are going to work, and soon we'll be having webinars. So Dr. Maheen, you can a little bit, you can just guide them regarding the research what we are planning.
Yeah, so for the research that we are planning, that so we have extended 1 week of the registration. I mentioned this earlier as well. We were having a huge influx of students who wanted us to kind of give them some time for registration. So we have extended the dates for a week, and after that, after this week, we'll be opening the payment portal for researchers so that you guys can pay, and we'll just start forming groups. So as of now, yeah, tomorrow we're going to be having a webinar where we will be having research mentors, and they will guide you a little bit about what they're going to do through the entire 3 to 4 months. They're going to give you an overall summary of what they plan to do over a course of 4 months. And yeah, I think that's it, Dr. Ahmed.
Yes, thank you so much, Dr. Maheen. Okay, so we'll be starting our session within 10 minutes. So you guys can have your 10 minutes of break and don't leave the meet. Okay, so yes, just take a break for 10 minutes and then we'll be starting our lecture. So today we are going to discuss dementias, a really important topic, and we are also going to discuss some UWORLD concepts as well. Thank you.
All right. Okay, guys, I'll see you tomorrow. Bye-bye. Take care.
Thank you, Dr. Maheen.
Bye.